All right, welcome everybody to PsychSIGN's official subspecialty speaker series. We are excited to start it off with Consultation Liaison Psychiatry. We have with us here today Dr. Zabinski, who is a Consultation Liaison Psychiatrist at Columbia University Medical Center. His interests include neuropsychiatry and critical care psychiatry, medical education, and clinical ethics. In addition to his work with the inpatient Consultation Liaison Psychiatry Service, he sees patients in the Columbia Ketamine Treatment Program. Previously, Dr. Zabinski trained at Johns Hopkins for residency, where he served as a chief resident in his final year, and was followed by a fellowship in Consultation Liaison Psychiatry at NYU. Welcome.
All right, thanks so much for having me. In the interest of time, I'll sort of give an abbreviated history. I know some of you may have heard some of the details that I was saying before we needed to jump to a new link. So I am originally from Ohio, went to undergraduate and graduate school at Case Western in Cleveland, where I studied engineering for my undergraduate degree, biomedical engineering, and then I did master's degrees in social work and bioethics. I was sort of finding my path. No one in my family is in medicine or healthcare. And I think that journey can be a little bit different if you don't have those exposures earlier. But ultimately made the decision to go to medical school instead of going and to work in clinical social work. I had done field work in kidney and pancreas transplant, psychosocial evaluations at the Cleveland Clinic for a year. And then I had done a year with the AIDS Task Force of Greater Cleveland, essentially in a role that's similar to an internship with housing case management, medical case management, that sort of work. In medical school, I didn't start out knowing what I wanted to go into. I think I sort of left everything on the table. I'm somebody who tends to enjoy whatever's available. Really enjoy bedside clinical work. And then when it came down to the decision time, I really got some excellent advice from trusted mentors who are in various fields that I was interested in, and in particular saw the career trajectories of the people who I admired most and who I thought, oh, one day I would love to be like that person, were disproportionately in psychiatry. And so I think it was something a lot of other people realized before I did, that was going to be the right fit for me, but I got there eventually. So consult psychiatry being one of the 5 ACGME accredited fellowships, at this intersection between medicine and psychiatry, it's interesting to kind of look back on some of the early hints, even in graduate school, for example. Those field placements are very much Ciel Psychiatry areas. And in fact, a consult psychiatrist was there and doing the psychiatric evaluations for transplant patients. So then the transition to residency. You apply all over the place and you like to think that you're really making very thoughtful decisions about everything. But I think at the beginning, it's just, this hope that you'll get interviews places and that you'll be able to have some exciting options. But it does feel like you're a little bit at the mercy of this complicated system when you're going through that. I was specifically looking for a program that had a very well articulated educational vision for the residents. There are plenty of programs that kind of map that out very specifically, but I liked the philosophy at Johns Hopkins for how they wanted to educate their residents. And then I also really liked that they had a strong medical training in the intern year. It's in some ways closer to a medicine intern year than I would venture to say almost any other psychiatry residency program. So I loved that. I liked the idea of sort of completing this next step of clinical training specific to medicine, and to hold on to that those interests at a higher level of training. So this is already setting me up for, okay, if these are the things I like, consult psychiatry is going to be a potentially good fit. And I think I was also particularly interested in neuropsychiatry, which also has fellowship programs, as well as geriatric psychiatry, another one of the ACGME accredited fellowships, and a place that you disproportionately see complicated medical situations, have to be very thoughtful about medication interactions, and use a slightly different set of treatments for some of your patients. So I was deciding between those, and I think the thing that you get in Ciel Psychiatry is you get this really great breadth. You see a little bit of everything when you're, especially in a hospital-based Ciel psychiatrist. And I loved that. Some of the most memorable patients I had in medical school and in residency were on the Ciel service. It's a little bit similar in some ways to being in the emergency department. And in fact, there are some psychiatric emergency departments that utilize Ciel psychiatrists for coverage of patients. So it's like this, I like that acuity, and you're making interventions that make a potentially huge difference in the patient and in the primary team's ability to treat that patient very quickly. So that's quite satisfying. And then you're also in some cases, the only time a patient has ever met a psychiatrist or ever will meet a psychiatrist. And so it's I think a really important space to set the frame, to have the expectations of what a psychiatrist is and what a psychiatrist isn't. And if done really well, you could get somebody into long-term care who might not have otherwise entered that treatment pathway, and it could make a huge difference in their life. So I think it's underappreciated how important the psychotherapy skills are at bedside with this patient population. So it's this great mix of quick bedside psychotherapeutic interventions and this, sort of the acuity of conditions that you sometimes get. So I thought that was a lot of fun. My Ciel Psychiatry rotation in residency was very busy and slightly unpredictable and extremely exciting. And so, I think that was one of the things that was the next step leading me towards the specialty as I was considering between those three sort of towards the end. When I was making the decision, I also had in mind, I wanted to go into academic psychiatry. I wanted to be in a big department with lots of trainees, where we would have things like journal clubs and researchers who are really at the cutting edge of what's coming next in the future of psychiatry. And it's just a really dynamic environment. I mean, we all kind of grow up in it professionally. It's the people who you disproportionately hear from in talking about their careers are people who made the decision to go into academic psychiatry. So there's certainly a bias of what you end up hearing about, but I love it. And I saw Ciel Psychiatrist as being particularly well positioned across a medical center to work with all these different departments and to really help fulfill the kind of role of that academic. So deciding then to do Ciel Psychiatry, it's one of the two specialties that have a match. So Ciel Psychiatry is a one-year fellowship. The other that has a match is child and adolescent psychiatry. You typically would apply this summer and early fall going into your fourth year of residency. And then the interviews kind of right thereafter, maybe August through November timeframe. And then the match is early January. So for me, it's a much less competitive situation than when you're going into psychiatry residency. So, there's something like 100 slots, let's say, and any given year, 70 or so applicants. So it's you can feel much more secure that if you would like to become a Ciel psychiatrist and do the training, that you'll likely have a slot. And likely have options, and that feels really good, especially after the other transition points in training that sometimes can be a bit more stressful. So I did my Ciel fellowship at NYU, which is a split between the three hospitals that are the primary training sites for for NYU, which is Tisch Hospital, which is kind of a very nice building and kind of feels like a modern private hospital. And then there's Bellevue, which sort of holds a very special place in the history of psychiatry, an enormous community hospital with hundreds of inpatient psychiatry beds, as well as beds that help to serve the prison population in New York. And then the third site is the VA, and it's the Manhattan VA. They're 1, 2, 3 right along on the east side of Manhattan, so very conveniently located near each other. There were 2 other fellows in my group. And we spent time on the Ciel service, but also rotating with specialty outpatient clinics that were in different Ciel areas. So for example, women's mood disorders and sort of reproductive psychiatry is a major area in Ciel. Transplant psychiatry, HIV psychiatry, neuropsychiatry. I rotated in a multiple sclerosis clinic. So these are some of the experiences that you have as part of the fellowship. And a lot of it is referral evaluation and recommendations. So the Ciel psychiatrist also is unique in that we end up making recommendations. We're not putting in the orders. And so it's a conversation that you're having with a primary team that consults you. And the primary teams have specific questions that they're asking. I know one of the questions that came up that I was forwarded before our session was talking about sort of what you see in a typical day and what some of the common consults are. And then we very, very frequently are consulted for depression, delirium, agitation, behavioral disturbances, capacity evaluations. Now, any physician, any primary team could do a capacity evaluation, but anytime that there's the suggestion that mental illness may be playing a role in a patient's ability to have a capacity for a particular decision, we're consulted and get involved. So that's commonly what we see. And then in my transition from fellowship to my faculty position in Columbia, I knew that I wanted to do Ciel Psychiatry, but actually I was open to all kinds of areas within psychiatry where you see this overlap between complex medical conditions and psychiatry. And so I was lucky enough that a position was available with the Ciel service at Columbia, where I did in my first year 4 days and this year 3 days with the inpatient Ciel service. And I'm the liaison to the neurology team as well as the neuro ICU. Now, I would say it's relatively rare that I get a consult from the neuro ICU, and I don't get 100% of the consults from neurology, but disproportionately, those are the ones that I see. I also see general consults. We're lucky enough at our program to have a dozen attendings. It's one of the largest Ciel services in the country. So we each have the advantage of this subspecialty area that we can really focus in on. And so we have 3 people who are transplant psychiatrists. We have a psychologist on the team who works in the ICU. We have people who are specifically dedicated to some of the medical units. So that's, I think every hospital has their own version of how a Ciel service can work, depending on staffing, hospital needs, and the patient population that you see. But I think that what we get is not atypical. It's just we have a bigger faculty, so we have these further areas of specialization. So I think maybe I can move to answering a few of the questions that were posed. So one was, what's the most exciting part of your job and what's the most boring part of your job? I think the most exciting part of my job is when I get something that's like a diagnostic mystery, and you get the consult and the question, especially when it's coming. So for my area, for neurology, when you get a consult on a patient and it says, well, we've done this set of testing, it still could be this, and that, they still have a broad differential. And but we also think it could be psychiatric, and can you help us? And I love a consult like that, and to look through, it's like, has the patient had head imaging and these full lab workups, and all of these things that as a psychiatrist you don't look at as frequently, but when it comes to these really tough cases, especially in CL, you're looking at every detail, and that's really fun. And working with the team to understand. I mean, I've been consulted on things where you get some subspecialty of another area in medicine, and they have their whole separate vocabulary and all of these acronyms that maybe I saw once in medical school, but it's a lot of learning on your part too, and so that's quite exciting. The most boring part of my job, I don't know. I tend to write quite a lot for my assessments and my evaluations, which it's because I think it's important, and I like to have the full thinking reflected on a complex case. But it can be boring sitting there documenting for a while. I think that's the only thing that really ever gets me. Some of the requirements that we have for various reasons, but that can be tolerated. It's not like I'm bored at work with any frequency. A typical day looks like in CL. So I think for most services, you would have a sort of designated start time, whatever that might be, where, maybe if there's a person who's covering for psychiatry in the hospital overnight, somebody might be covering, for example, the emergency department, the CL patients, and the inpatient unit. And so you may get a brief sign out from somebody who was on overnight. And then any new consults that came in that they weren't able to see would be kind of first order of business. Usually you call the primary teams to get what their detailed question is that they would like you to answer and what they need your help with. And then you move from there to chart review, preparing notes, and then seeing patients. And I would say particularly, it depends on how your service is structured. You spend a lot of time in patient rooms, in documentation rooms, in finding primary teams, in a lot of walking. So that's probably what a typical day looks like. It's generally a sort of 9 to 5 sort of situation for most services. It just depends on the how things are arranged, and how that coverage is arranged. There's some services that will say any consults that come in after a particular time, unless they're emergent, won't be seen until the next day. And that's quite common, that there's a sort of formal or informal cutoff like that. Different career options for CL psychiatry. So I think, what I'm talking about is a CL psychiatrist in an academic center, but community hospitals also have a consultant psychiatrist, and those services tend to be quite busy, may see many more patients in the course of a day. So it's very exciting in that sense. I think for me personally, there are aspects of that I might even feel are a little bit overwhelming. I like the volume of the consults where I am now. I could probably handle an even higher volume, but at some point there's a limit, and so to prevent burnout and to make sure you have balance, I think that's something that is a really good question for a CL psychiatrist who's looking for a job, is what's your typical volume of consults? Why should someone choose to subspecialize in your field rather than stick with general psychiatry? This is a good question. There are plenty of people who are trained in general adult psychiatry who go on and become CL psychiatrists without the fellowship training or board certification, because there's such a demand. But you'll find those, you would be able to do that in more of a community setting and in more of a high need setting. If you wanted to be in an academic center, the fellowship is really beneficial. I think it's that extra polish, so to speak, on some of the skills that you need to have the fellowship, and to really understand in greater detail some of the interactions that are necessary to really be highly effective at your job instead of just proficient. So I think if you have a niche area within psychiatry that falls within the CL umbrella, it can be a good opportunity to explore that in greater detail. And finding a fellowship program that would allow you to do that is very easy. And in fact, that's the topic of many sort of rather fellowship interview sort of questions. There was a question about the dual residency programs in psych and internal medicine, or psych and family medicine. There's also psychiatry and neurology. I think the reason to do something like that instead of doing general adult psychiatry and then doing the subspecialty would be if you were interested in actually practicing internal medicine or family medicine or neurology. You get the engagement with those fields as a consult psychiatrist, but you're not practicing you're thinking exclusively about the sort of the interaction between the medical and psychiatric, and it does require a certain degree of understanding, but you're not actually practicing. And I know this is sort of like, of course, that's obvious, but it does end up making a difference in when you're if you were trying to figure that out specifically. And I worked with some of the dual trained psychiatry and neurology folks, the trainees, as well as those who were trained in that area when I was in fellowship. NYU has one of those programs. They were amazing. And I really appreciated this sort of like dual way that they were thinking. It was interesting to see what they then went on to do. Some would practice in an area of neurology that had disproportionate amount of sort of psychiatric pathology. Something like functional neurologic disorders. I think that's a really good example of an area that they might practice in, where they're putting on both their neurology and psychiatry hats. But it's not every disorder that you would treat that you would need to have both the sets of training. So it's really about whether you want to be a psychiatrist first, or if you wanted to be able to practice in both of those areas. And you'll meet people who came from other specialties who then did psychiatry, who are practicing in SEL capacity, and they're excellent. They're part of the Academy of Consultation Liaison Psychiatry, and they're really good contributors. But I think that if you're looking ahead into training and trying to plan your own path, I think the decision, it's sort of obviously the decision has to be made how you're differentiating a bit earlier so if you're doing a dual or combination program, as opposed to in psychiatry, you would then have the opportunity to explore more and see if Ciel Psychiatry was the right area for you. All right. Balancing Ciel Psychiatry with a private practice. So it's interesting. So I would say a number of Ciel psychiatrists in our division have historically had private practices. And then my work with the Ketamine Treatment Program and with the faculty practice at Columbia is a little bit of a version of that. And I think it's really just in how you want to negotiate as you're setting up your time for a position somewhere. They tend to be, CL positions are not just commonly available in an academic setting. It's a little bit of luck any given year, what might be open and available. And actually taking a hybrid position gives the department a little bit more flexibility and gives you a little bit more flexibility. So I would say it's very doable, and in fact is quite a nice way of doing things. You could either have a private practice, say half a day, 2 days a week, and on a CL service that might have more than one person, that would be really easy. And it becomes more challenging if you are the CL team at a particular hospital. Then you would be seeing your private patients after hours or on weekends. And that would be much more difficult, just simply because of the number of hours that you would be working potentially, and the possibility for burnout. One of the questions was most frequently consulted area, and I touched on this before. I think delirium and capacity questions, sort of agitation is one, so hyperactive delirium, and so yeah, I think you have to find some of that to be fun and thinking about like the behavioral manifestations of rather psychiatric manifestations of medical illness, including, you know, mood, behavior, all the components. How does the training help your career in psychiatry? Again, I think it certainly is very helpful if you're interested in having an academic career in psychiatry, and gives you an opportunity to learn a new system, see these specialty areas within Ciel. And then that question also included, is Ciel for people with strong interests outside of psychiatry who want to see different types of patients? I think that's a fair way to characterize it. You know, if you, as I've said with some of the comments before, if you're interested in these other areas of medicine, you know, you still get to engage with those, even though you wouldn't be practicing in them. I see there's a question about how I became involved in the ketamine treatment program and my role there. So I haven't talked about that yet. So it started out by the department sort of having a need for an extra person to be participating in the program. And what I like about it is it's structured similarly to the way you would do a consult. There's a consult question when you're seeing a new patient, and that is this patient appropriate for treatment with ketamine, either intranasal or IV ketamine or some other interventional approach, so TMS or ECT or something like that. And so that's really fun. The patient has a primary psychiatrist, you're consulted to see whether this treatment is appropriate. We're right now doing intranasal ketamine, which is treatment 2 days a week for 4 weeks, and then 1 day a week for 4 weeks after that, and then a taper if the patient responds. Yeah, so I think it's in many ways, some of the things I enjoy about Ciel Psychiatry are represented there, even in the patient experience. And that's somebody comes to you oftentimes with quite severe symptoms. And then by the middle of treatment, oftentimes they really have improved considerably. A majority of the patients who we treat in the program who are highly treatment resistant, oftentimes with very complex histories of medications and sometimes complex medical histories too. You see them get better, and that's amazing. I could tell you story after story of patients who have had lengthy histories of really severe illness who have gotten better. And I mean, of course, you take with that patients who maybe weren't a perfect fit, and occasionally people who don't respond and unfortunately are quite disappointed, but we always have more options and more things to refer to. So I hope that's helpful in thinking about it. It's sort of serendipity that I became involved, but I think it's a really good fit. And actually, I think if that's something that is sort of exciting to you, or the idea of psilocybin or MDMA and some of these psychedelic assisted psychotherapies, I think that Ciel may have a role in the future of those programs at institutions across country because of these reasons that I'm saying. Talking about patients who may have medical complexity and who may have just an attention to detail that would be really important to ensuring good outcomes and safe outcomes for patients. Let's see. Did I rotate in this subspecialty? So as a medical student in my 3rd year in my clerkship rotation, part of it was on a Ciel service. And so I saw it quite very early. And then in my 4th year, I actually did a visiting rotation in San Diego on a Ciel service. And I loved it also. And then when you're a resident, so you don't see it again in residency. Well, it depends on the program. I didn't see it again in residency until my 3rd year. And you do time with the consult service there. And yes, how many rotations did I complete, and how did I use that to stand out on my application? Yeah, I think it depends on the department, and it depends on what your career trajectory interests are. But if you like Ciel Psychiatry, there are a handful of programs that I might think of, places that give you better or at least more comprehensive medical training. disproportionately are places that could lead to becoming a good Ciel psychiatrist. And they don't always have the fellowship, they may not even have a fellowship program, but I think that that's a good place to start. Yeah, so as one of the questions is, how did I eventually become interested in the subspecialty? And as I said, it's sort of all along the way, there were these things that were highlighted, that looking back, it was sort of the trajectory towards it. Day-to-day, do you find day-to-day life draining as a psychiatrist in this subspecialty? Important to seek therapy as an outlet in the subspecialty, and do you work with, okay, so I'll start with that part. Day-to-day life draining as a psychiatrist in this subspecialty. So, I mean, I think it's how your job is set up. I personally don't. I think it's really great, and I feel refreshed even after a fairly busy day. I mean, you have ups and downs with patients that you're caring for. People don't always have the outcomes that you would hope medically also, so that can be hard. And so I would say there are times where it can feel emotionally draining in that sense, but I find that the times where you have a particularly intense experience like that are far enough between that it doesn't just feel like a constant stream of emotional events. And I think that's something that depends a little bit on who you are and how you respond to patients in a clinical setting. And so hopefully through the course of your training, you'll get a good sense of whether this is a specialty that you would find draining personally, or if it's something that you find energizing and exciting. And then the next part of that question was whether or not it was important to seek therapy as an outlet in this subspecialty. And I think that just across the board, psychiatrists, but any other specialty, thinking about taking care of yourself, your own mental health and wellness is always important to have as a priority so that you're able to give the patient your very best. And so in that sense, I think it's important. Does it have a special importance for a consult psychiatrist? I wouldn't say so. I think it sort of holds equal importance to other specialties that you would see. I think, there is an argument to be made for having a therapy experience yourself to give you insight into sort of what the differences in dynamic are as a practitioner, as a patient, but by no means do I think it's something that should be required. Though there are people who would argue that maybe it should be for psychiatry residents to be in therapy themselves. But I'm not aware of programs that require that at this point. Do consult psychiatrists work with other doctors to improve patient outcomes? Absolutely. That's kind of the day-to-day life of a Ciel psychiatrist, is doing exactly that. Is this a competitive field currently? I wouldn't particularly say so. Reflected in the numbers that I was giving before. In any specialty or subspecialty, there are going to be a couple programs out there that are more competitive, no matter how you kind of stack things up. But in general, it's a very collegial field. It's a really great community. You go to the Ciel Psychiatry annual meeting is small enough that you can really get to know people. Yeah, so it's just a really nice experience. Let's see. Any other question on that one? Oh, now that, do you believe that step 1 score was weighted in the selection process, and now that step 1 is pass fail, do you think step 2 will be heavily weighted? So it's a good question. I think it applies more for residency application than it does for the subspecialty. I could be wrong, but at least in my view, the step exam scores are not particularly reflective of your ability to succeed in this subspecialty. And there may be programs that take them into more detailed consideration as you apply to this specialty, but not that I'm aware of. So I think for residency application, no doubt that that having a good score on step 2 will be an advantage. But to what degree it's weighted, it's certainly not weighted as strongly as in, as of the last time I saw the data, it was emphasized in psychiatry less than any other specialty. And even with the evolution of the step exams, I would anticipate that would remain true, just because psychiatrists are really thinking in, the same way we think of for patients in a sort of their life context and their behaviors and in the diseases that they may have in this sort of biopsychosocial framework. I think so too do we expect a holistic evaluation of trainees and peers as you're imagining what that would look like. It's inevitable that you're going to have some metrics that people are looking at, but again, I think de-emphasized relative to other specialties. There's a question about pay difference between general psychiatry and those who are Ciel trained. Ciel psychiatrists, on average, probably make a little less than a general adult psychiatrist. But there are so many caveats to that statement that it almost makes it irrelevant. You can find high-paying and low-paying positions in any area of psychiatry, practically. What tends to make the difference is how many patients you're seeing, what that setting is like, how much support you have, and so how things are structured. But I can say that in an academic setting, typically the starting for a Ciel psychiatrist is a little bit lower than an inpatient psychiatrist, for example. And then outpatient psychiatry really depends on what area of the country you're in and how busy you want to make your practice. But in New York, for example, a well-trained psychiatrist can open up a private practice the day after they finish residency and be filled very quickly and can charge a lot of money. And there's sort of advantages and disadvantages to that being true. I think it's unfortunate in some sense because it creates this barrier to entry for patients who may not have the resources to access that care. Though a psychiatrist who is really feeling financial pressure for whatever reason and needs to kind of make something like that work would be able to. So I think as a Ciel psychiatrist, as I mentioned before, you have a little bit of potential flexibility in structuring your time. Maybe you can have part-time private practice and part-time with Ciel, something like that. Okay. If there are other questions, I would be open to them. I would also add that I would be happy to share my email address with everyone. If you wanted to reach out with questions about residency or fellowship or this field, I would be more than happy to take those questions offline also. Yeah, I hope it's conveyed a little bit in the way I talk about some of this, but I really, really love what I do. I love almost every aspect of it. I think the colleagues that I have are amazing. I think the conferences I get to go to are always so much fun. Even the virtual version, it's not as much fun as being there in person, but even that was exciting. Recently, we had our annual meeting. So membership in the ACLP, the Consultation Liaison Psychiatry organization, is free for medical students. And they have a wealth of information. It's helpful in clerkships, helpful for application to residency, helpful for residents that you can access through there. So yes, so please take a look, join, and reach out. Are there other questions that we can do now? If anybody has any.
Yeah, hi everyone. Feel free to unmute and ask questions that you have. I think we went through the list of all the submitted questions. Thank you so much, Dr. Zabinski, for your time. Thank you all for working with us on this meeting.
I do have a really brief question. Dr. Zabinski, would you feel comfortable dropping your email in the chat?
Yes, that would be just fine.
Thank you.
It'll take me a second to type it, so bear with me. I don't usually use my iPad for this kind of stuff. Okay. Okay, that should have gone through. It's jz3291@cumc.columbia.edu.
Thank you.
Yeah, no problem.
Great. Well, thank you all for being here. I hope you have a wonderful rest of your evening, and this recording will be on our channel soon. Thank you so much.
Great. Yeah, and thank you so much for putting this together and for working through the technical difficulties that